In this lecture, I'm going to provide a brief review of the anatomy and physiology of the urinary system, but our primary focus is going to be the lower urinary tract because our scope of practice focuses on patients who require urinary diversion because of removal of the bladder, or patients with urinary incontinence, which involves dysfunction of the bladder or the urethra. So we'll talk very briefly about upper tract function, but we will focus primarily on lower tract function and on aspects of function that are relevant to our patient population. So we're going to quickly look at the kidneys, and just a quick overview. You already know that the kidneys are located in the retroperitoneal space, which of course provides them with a lot of protection because that means they're outside the abdominal cavity, and that any problems within the abdominal cavity, such as peritonitis, have no impact on the kidneys. The major sections, as you will remember, the cortex, the outer section, this is where urine production takes place, primarily in the cortex and the medulla, and then urine delivery begins in the renal pelvis and into the ureters. Now you remember from school that the nephron is the key functional unit of the kidney. That's where urine is produced, is within the nephrons. And we're going to talk a little bit more about the specific function of the nephrons in just a minute. Then the last general fact to review related to overall kidney function, we know that there's a very important connection between renal function and hemodynamic status. Now normally the kidneys receive 20 to 25% of the cardiac output each minute. So that means with every beat of the heart, 25% of that blood goes to the kidneys. We really know this because if we have a patient we're concerned about hemodynamic status, we watch their urine output very carefully. And if their urine output starts dropping below that magic number of 30 milliliters per hour, then we're very concerned about hemodynamic status, about the need for additional fluids, etc. In addition, we know that when patients are in shock, when their cardiac output is very diminished, that there can be major damage to the kidneys. We know that failure to provide adequate blood flow to the kidneys can actually result in acute tubular necrosis. So that interchange. We can monitor hemodynamic status partially through monitoring urine output, and we know that if there is a major problem with hemodynamic status, the kidneys are the organ most likely to be damaged. Now, the critical functions of the kidneys, and again, I don't want you to get lost in this. I don't want you to spend a lot of time memorizing all of this. I want you to know the general functions of the kidneys. I really think you already know all of this, so we're going to go through this briefly. And then I'm going to focus on the things that I do want you to know. So if we get to a section, and I know that it's important to your role as a WOC nurse, I will tell you, and I will tell you to study it. So right now I'm going to tell you that you need to know the overall functions of the kidneys, not in detail, but big picture. So what do the kidneys do for us? You do know this. You certainly know that the kidneys make urine, and that in the process of making urine, they eliminate protein waste. So we're very clear on that. We also know that in the process of producing urine, kidneys maintain our fluid electrolyte status and maintain acid-base balance, because the kidneys have the ability to retain needed electrolytes and to eliminate any excess. The kidneys have the ability to retain or eliminate hydrogen, to retain or eliminate bicarb. We'll come back to that very briefly. The kidneys also contribute to blood pressure regulation and to production of erythropoietin and to activation of vitamin D. So a whole list of functions for which the kidneys are responsible. We're all very tuned into the fact that the kidneys are absolutely essential to life. You don't have to have two, but you do have to have adequate renal function to maintain life and health. Now we're going to talk specifically about urine production. I'm going to go through the general process of urine production. I don't want you to focus on that. Then we're going to talk about specific characteristics of urine that are relevant to our patient population and to what we teach our patients. And I will be very clear about what it is you need to know. So let's look at the process of urine production. Here's that nephron that I'm sure you remember fondly from school. There's actually two major phases of urine production. The first phase of urine production actually takes place at the level of the glomerulus and Bowman's capsule. I should have brought my pointer, but I'm going to try to reach. So here you have the glomerulus and the surrounding Bowman's capsule. And you know that the glomerulus is a network of capillaries. And you know that blood is pumped into the glomerulus under pressure. If you have blood forced through a capillary network under pressure, then a lot of the fluid is going to be forced out of the capillaries into the surrounding tissue. Some of the electrolytes are going to be forced out of the capillaries into the surrounding tissue. It's simply a matter of pressure. In the glomerulus, every day you get 180 liters of primitive urine. So let me just go through this one more time. You think about, you've got all of these little nephrons, and every nephron has a glomerulus. And as the blood is pumped through the glomerulus, a lot of the fluid, electrolytes, a few cells are forced out of the glomerulus into the surrounding tissue. And in this case, into the Bowman's capsule. If you take the total sum of all of the fluid that is forced out of the capillary network into Bowman's capsule over the course of a day, it's 180 liters. That is phase one of urine production. Now, the problem with phase one is that it's very non-selective. It's simply pressure-based, and so you end up with this excessively high volume of filtrate or primitive urine. That points out the importance of phase two, which is selective reabsorption. Thank goodness we have phase two. Phase two takes place in the tubular system. The tubular system, of course, as you can see very clearly here, and to some extent here, the tubular system is surrounded by a capillary network. So as this primitive urine flows through the tubular system, there's a constant exchange between the tubules and the capillaries being the bloodstream. The primary effect is reabsorption. So most of that 180 liters are reabsorbed back into the bloodstream. There is selective reabsorption of electrolytes. So needed electrolytes are pulled back into the bloodstream. Unneeded electrolytes are allowed to continue to flow through the tubular system into the renal pelvis and eventually into the bladder. So two phases. Phase one produces very high volume primitive urine, very dilute filtrate. Thank goodness we do not have to void 180 liters a day. And fortunately, we do not have to replace 180 liters a day, or our whole lives would revolve around intake and output. Because we have the tubular system, almost all of that fluid is reabsorbed, and you go from 180 liters of urine production to 2 liters. So the end result, 2 liters of urine approximately every day. And more importantly, selective reabsorption of electrolytes, active elimination of breakdown products from medications, active elimination of waste products from protein metabolism. And then the third element is urine transport. And urine transport begins right here once you get to the collecting tubule. Notice that there's capillary networks surrounding the entire tubular system until you get to the collecting tubule. And once you get to the collecting tubule, there are no capillaries surrounding this component of the tubular system because now urine production is complete. Urine is final. Urine concentration and components are final. And now we're into urine transport. So the nephron, responsible for urine production, then the very last component of the tubular system, the renal pelvis, the ureters, and the bladder, responsible for transport and elimination. Now the next section is important, and you can see the things in bold that I particularly want you to focus on. I want you to be very aware of normal pH and factors that impact on pH and why it matters. We're going to go over that in detail. We're going to talk a lot about factors that increase urinary odor, and I'm going to tell you why that matters. And we'll talk briefly about constituents. Now, volume, you already know, is extremely variable. It depends on how much fluid intake there is. So you know, you take yourself, and if you have a very busy day at work, you really don't have time for a break, you barely grab crackers and a glass of water at lunch, then your output is going to be markedly reduced, and you'll notice that your urine is concentrated and you have much less volume. In contrast, if you're out with friends, you're over at someone's house, you're eating and drinking, and you have high volume fluid intake, you're going to have much higher volume output. So ranges from about 750 to 2,000 milliliters a day, extremely variable depending on intake. I'm not going to ask you that. I will ask you about pH. I want you to know that the pH of normal urine is slightly acidic, and that acidity is very important to health for several reasons. First of all, and probably the most importantly, is an acid environment is hostile to bacterial growth. So keeping the urine acidic helps to reduce the risk of urinary tract infection. Secondly, acidic urine has much less odor. You think about that very strong ammonia smell that occurs when you have somebody in absorbent products like diapers, or when urine sits for a period of time, you have very strong urine smell. We associate it with a strong ammonia odor. That's that very alkaline smell. So if you keep the urine acid, not only do you have lower incidence of urinary tract infection, less risk of urinary tract infection, but you also have less odor. Finally, if urine comes in contact with the skin, it's less damaging to the skin if it's in that acid range, because that matches the normal pH of the skin, which is also slightly acidic. In contrast, if the urine becomes very alkaline, number one, it's much friendlier for bacteria, so you're much higher risk for UTI. You have more odor, and you're much more likely to damage the skin. So for almost all patients, the goal is to keep the urine in that normal, slightly acidic range. Now let's talk about the factors that impact on pH, because we're talking about patients with urinary diversions, we're talking about patients with urinary incontinence. We want to keep the urine acid so that it's skin friendly, so it has less odor, and so that it's hostile to bacterial growth. So we need to know which factors impact on pH so that we can manipulate those factors, or help our patients to manipulate those factors to keep the pH where we want it. Now, the first factor is diet, and actually you're going to pay the least attention to this one, because you don't ask a patient to change their diet from a vegetarian diet to a meat-based diet just because of urinary pH. I can't imagine doing that. Diet has the least impact, but it does have a slight impact in that a vegetarian diet is slightly more likely to produce alkaline urine than a meat-based diet. That's not a reason to encourage people to maintain a meat-based diet, and again, we would never ask a vegetarian to switch over. The other two factors are much more important, and those are the things I want to focus on, and those are the things that we want to address. What I'll definitely ask you on the test is the impact of volume of fluid intake and type of fluid intake. That is the most significant factor in the determination of urine pH. With normal production, in the situation where the patient has adequate fluid intake, typically urine will be acidic. You increase fluid intake, you're going to help push urine toward the acidic range. If you decrease fluid intake and the urine's more concentrated, you tend to push urine toward the alkaline range. So one of the first things we say to our patients is make sure you're drinking plenty of fluid. There's multiple reasons for this for the patient with the urinary diversion. We'll cover those in a later class. But one reason is that adequate levels of fluid intake help to maintain an acidic pH. Now, the other thing that impacts is the type of fluid. If the patient is primarily drinking water-based fluids, that is going to tend to push the pH toward acidity. If the patient is drinking a lot of citrus, dairy, or carbonated fluids, that tends to push the pH toward the alkaline range. So I focus first when I'm talking with my patients on volume. Let's go through a typical day. Tell me what you drink for breakfast, tell me what you drink between breakfast and lunch, what do you drink at lunch, etc., etc. So I look first at volume and make recommendations to assure adequate volume of fluid intake. Secondly, I will look at type of fluid, and I will encourage the patient to reduce carbonated fluid intake. So if they're drinking, say, a lot of ginger ale, Coke, Sprite, I'm going to encourage them to substitute flavored waters, herbal teas, something like that, for some of those carbonated drinks. Same thing if the patient's getting in a lot of milk, because milk can push the pH toward the alkaline range. Now, that doesn't mean 1 to 2 glasses of milk a day. I'm going to give you an example in a minute, but I'm talking, what if that's all the patient drinks? Or like some of my spina bifida kids primarily drank chocolate milk, orange juice, and Coke. And they had major problems with alkaline urine and odor and skin breakdown and infection. So not only did I need to work with them and their parents to assure adequate volume, but I needed to make specific suggestions about changing some of the type of fluid intake. One of the most confusing things for most of us is the fact that if you drink a lot of citrus juices, even though those citrus juices are acid, it causes the urine to be more alkaline. And I can't really explain this except to say it has something to do with Krebs cycle. So that when that orange juice or grapefruit juice goes into the system, it's acid. But once it goes through the metabolic pathways, the metabolic end products are alkaline and push the urine toward alkalinity. So when you're looking at fluid intake, things that should raise red flags: not enough volume, high volume dairy, high volume carbonated, high volume citrus. What we want is for at least half of their fluid intake to be water-based. And of course, the end result that we want is dilute, acidic urine with minimum odor. Okay, so let me tell you this story. It'll probably help you remember. I had this patient, his name was Hubert. He had an ileal conduit, and he had major problems with meltdown of his wafer on his pouching system. He could only keep a pouch on 1 to 2 days. He had major problems with odor. He had some problems with skin breakdown. He had fairly frequent urinary tract infections. And when I talked to him, first of all, when I checked the pH of his urine to determine whether or not it was acid or alkaline, it was very alkaline. When I went through his fluid intake with him, his volume was fine, but almost all of his fluid was milk-based. That's about the only thing he drank. He loved milk, and so he drank milk all day long. He usually drank 1.5 to 2 quarts of milk a day. So it essentially was all he drank. I had had multiple conversations with him about changing his fluid intake, but he's like, I don't want to change what I drink. I'll just deal with this. So then he comes in one time, and the staff is like, wow, Hubert's in for a checkup and everything's different. His pouch is staying on. He hasn't had a urinary tract infection in months. I didn't smell anything when I was in the room. What do you think's changed? I'm like, I don't know, but I'm going to go in there and find out. So I went in. His wife was with him. And I'm like, Hubert, you know, I'm hearing great things. I'm hearing that your skin looks good. You're not infected. I can tell there's not nearly as much odor. It looks like your pouching system is staying on much better. His wife's like, I can explain that. And so what she told me was he had had a mild stroke. He was doing well, but there was a 2-month period of time when he couldn't drive. And so she did all of the shopping. And she rationed his milk. So she would buy a certain amount of milk, and she told him, this is all you get for the week. And I've got all of these other things for you to try to see what else you like. There's got to be something else you would like to drink. Well, he had no choice except to drink other fluids, and she had been in on every discussion I had had with him. Well, within a week of having his milk rationed, both of them could tell a major difference. And then that convinced Hubert, and he finally changed his approach, which changed his outcomes. So just be aware that type of fluid intake can make a difference. It's something you always check for. The third thing that impacts on pH is urinary tract infection. Our goal always is to prevent urinary tract infection, but we do want to be aware that some of the organisms that cause a urinary tract infection can split urea, cause increased production of ammonia, cause increased odor, and shift the pH toward alkaline. So implications for us, as you see on your handout, is we're always trying to maintain acidic urine unless there's a specific contraindication. Talk a little bit about that in another class. How do we do that? Adequate volume of fluid intake, control the intake of carbonated drinks, dairy products, and citrus juices, and of course, preventing urinary tract infection. Now, if we have a patient who has a really hard time keeping the urine acidic, maybe the patient is a vegetarian, and even though the patient's getting enough fluid intake and has shifted the type of fluid they're drinking, still their urine tends to be alkaline. You could talk with the patient and the physician about adding vitamin C tablets. Vitamin C tablets do help to acidify the urine, because when you give the patient a vitamin C tablet, it doesn't go through that metabolic process, so it has an acidifying effect. So it's really interesting that orange juice and grapefruit juice tend to make the urine alkaline, but vitamin C tablets help to keep the urine acidic. Now, the other features of urine, color you already know, quite variable depending on concentration. I'm not going to ask you that. Odor, I will ask you about odor because it's very important. First of all, urinary pouches are not all odor-proof. A lot of the urinary pouches are odor resistant. That's because the urine odor molecule is much smaller than the fecal odor molecule, and it's very hard to create a plastic film that totally contains the urine odor molecule. Companies have used different approaches. Some of them layer the plastic film, others have modified the plastic film. But the reality is that many of the pouches on the market for patients with urinary diversions are odor resistant. What you might hear from a patient is, I put my pouch on Monday, I don't smell anything on Monday. By Tuesday night, I'm starting to smell it a little bit. By Wednesday, I really smell it, and my wife can smell it too. So we want to make sure that we do everything to minimize the odor associated with urine. A lot of the things that minimize odor we've already talked about: keeping the urine dilute through adequate volume of fluid intake, keeping the urine acidic by looking at volume of fluid intake, type of fluid intake. But we also want to look at the impact of foods, fluids, and medications. There are some foods that cause a major increase in urinary odor. Probably the one that comes to mind fastest is asparagus. So some of you have noticed that when you eat asparagus, your urine smells like something died. And that has to do with an enzyme that some of us have and some of us don't have. So some people can eat asparagus and it causes no change in urine odor. Other people, when they eat asparagus, they're very, very aware. They might have forgotten they had eaten asparagus, but when they go to void, they remember. So we want to talk to patients about things that can make urine odor worse. I can tell you, if I had a urinary diversion, I would not eat asparagus. Or I would only eat it on the evening before I was going to change my pouch the next morning. Because when I eat asparagus, there's a major change in the odor of my urine, so I would be very aware of that. Some people notice that fish causes a change in the odor of their urine. Some people notice a change with garlic and onions. So you tell people, pay attention to any things that seem to cause your urine to have greater odor. You also notice that some medications like antibiotics and vitamins can increase urinary odor. So since this is going to be a huge issue for patients with urinary diversions and patients with urinary incontinence, we want to help patients sort through the things that can increase urinary odor, decrease urinary odor, so that if it's an issue for that patient, we can help them solve it. Now, if the patient says, you know, I never notice urinary odor, my wife never notices it, or my family never notices it, okay, great. Then we don't have to be nearly so worried about what they eat, what they drink, that kind of thing. But if a patient is having significant problems with urinary odor, we want to go back and look at what they're eating, what they're drinking, the type of vitamins they're taking, when they're taking their vitamins, that kind of thing. Specific gravity is going to be variable. It depends on, how much water fluid you're getting in. And then the last thing, constituents. Usually this is not significant, but I put it on here as reference because in some situations you'll have a patient who is post-op for a urinary diversion, and the patient starts to have large volumes of clear fluid drainage from their surgical drain or leaking through their incision. And the question becomes, is there a leak at an anastomotic site, and is this urine leaking through the surgical drain? Is this urine leaking through the incision? Or is this just, serous fluid? Many times they will ask you to pouch the drain or pouch around the area of the incision that's leaking so that they can get a specimen, send it to lab. In the lab, they can analyze it to determine, okay, do the constituents of this fluid match urine or plasma? So we know that urine typically has no glucose or very low glucose levels, whereas it's normal to find glucose in the plasma. Same thing with protein. So that's just there for reference. I'm not going to ask you that. Okay, what else do the kidneys do? Well, we've already said that the kidneys maintain fluid and electrolyte balance. ADH, let me back up. ADH is the primary control factor for water balance. So you think about how ADH works. If you are not getting in enough water, not getting in enough fluid, then your plasma becomes hyperosmolar. It becomes more concentrated. And you have little receptors in your large blood vessels, little osmoreceptors. So as the concentrated plasma flows past those receptors, they pick up that the plasma is becoming more concentrated. They signal the pituitary to produce ADH. And you think ADH, anti-diuretic hormone. It's your water conservation hormone. When ADH is produced, what it does is it acts at the level of the distal tubule. And at the level of the distal tubule, it alters permeability of the peritubular capillaries to increase reabsorption of water from the distal area of the tubular system. So you see what that does, it pulls water out of the urine back into the bloodstream. Anti-diuretic hormone. So when you need more fluid, you make more ADH. ADH pulls water out of the urine back into the bloodstream and restores your fluid balance. Now, there are situations that impact on ADH production. Following surgery, you've probably noticed that patients go into a period of fluid retention. Following surgery, following trauma, major physiologic stress. During this period of time, you do not make ADH, okay? And, no, sorry, back up. During this period of time, post-op, post-trauma, post-stress, the pituitary is cranking out ADH because the body's in stress response and it's in water conservation mode. It's like, hang on to water, we might need it because something's going on. They cut us open. They hurt us, okay? We're under stress, and so the body goes into hang on to fluid, hang on to water, just in case. So the pituitary is making ADH, even though the plasma is not concentrated. Other signals are telling the pituitary, make more ADH. And so water is being pulled out of the urine, back into the bloodstream, out of the urine, back into the bloodstream. And that's when patients become, somewhat fluid overload. That's the situation they find themselves. They're kind of in an overload situation because the pituitary is making ADH. They're hanging on to all that fluid. But 2 to 3 days after surgery, the body kind of gives a big sigh of relief. Okay, we survived. Everything starts to normalize. ADH production stops, and the patient starts to diurese. So surgery, trauma, stress causes increased production of ADH and causes you to hang on to fluid whether you need it or not. Now, in terms of factors that block ADH production, the primary one is alcohol intake. So you think about when people are drinking alcohol, they're usually also eating things that are salty. So they really need more fluid. Their plasma's becoming more concentrated. But alcohol totally shuts down ADH production. So even though you need ADH, you don't make any. And so you just keep voiding, keep voiding, keep voiding. And what happens is you get dehydrated. And that's the basis of hangover symptoms. People are dehydrated. So they wake up the next morning feeling terrible, right? Their mouth is so dry, they have a pounding headache, they're nauseous, all dehydration. So surgery, stress, trauma, increases ADH production, alcohol stops it. Oh, sorry. What about electrolyte balance? The major two electrolytes, sodium and potassium, absolutely critical to cellular function throughout the body. So the body has a mechanism for maintaining normal sodium balance, normal potassium balance. It's called aldosterone. You make more aldosterone if your sodium levels are low, if your potassium levels are high. Aldosterone makes you retain sodium and lose potassium. That's not what I'm going to ask you. I'm going to ask you about the potential for electrolyte reabsorption in the patient who has a urinary diversion. And I want to explain this using the things on the slide. So you think with normal function, when you have your intact bladder, urine is produced by the kidneys, then it flows through that collecting tubule into the renal pelvis, ureters, and into the bladder. And as we've already said, once the urine flows into that collecting tubule, all modifications stop. Urine is final, is the final form of the urine. And it doesn't change as it sits in the bladder because the bladder is lined with epithelium, not with mucosa. So no change in the composition of the urine occurs while the urine sits in the bladder waiting to be voided. Now let's talk about a patient who has bladder cancer and they have to remove the bladder and they do this ileal conduit. And the whole concept of ileal conduit, we'll come back to this in more detail, is that they take a small section of ileum, they close that section of ileum on one end, they bring the other end out as a stoma, they connect the ureters. So now the urine flows from the kidneys through the ureters into this little section of bowel and out. But the little section of bowel is lined with mucosa, and that mucosa continues to try to absorb. So when they first started doing ileal conduits, we had a number of patients who developed this reabsorption syndrome. And as you see on your handout, what happens is that you pull sodium and chloride back into the bloodstream, and you eliminate potassium and bicarb. So what happened was they got this reabsorption syndrome known as hyperchloremic, okay, because of the reabsorption of chloride, metabolic acidosis, because you've lost bicarb, with hypokalemia. Well, urologists caught on very quickly, and what they did was they made sure that conduits were short and straight, because as long as your conduit is short and straight, the urine flows through quickly, you minimize contact between the urine and the mucosa, and this reabsorption syndrome is very unlikely to occur. So it was much more common in the past, very unlikely at present. I just want you to be aware of it. Sometimes they ask about this on the certification exam, so there it is. We won't ask about it on our exam, but we do want you to study it when you get ready for certification. Okay, what else do your kidneys do for you? Well, they maintain acid-base balance. There's a lot of complex equations that take place in the kidneys every day. I'm so glad my kidneys understand chemistry better than I do. If it was up to me, I would have died a long time ago. But my kidneys are pretty smart. Your kidneys are very smart, and this is what they do. If you have a patient who is acidotic, maybe a diabetic patient who has high glucose levels and who is in acidosis, what happens is they end up with very high levels of hydrogen. Hydrogen represents the acid component of the acid-base system. In that situation, what the kidneys would do, they would actively eliminate the hydrogen to bring hydrogen levels down, and they would actively reabsorb bicarb. So if you bring your hydrogen levels down, you bring your bicarb levels up, you reestablish balance. If, on the other hand, you had a patient who was in alkalosis, what the kidneys would do is so you've got high levels of bicarb and low levels of hydrogen. In that case, the kidneys would dump bicarb, hang on to hydrogen to restore balance. So the kidneys can do what needs to be done to maintain acid-base balance to a large extent. They can help compensate for problems within the acid-base system. I'm not going to ask you that. Blood pressure regulation, partially by control of fluid balance, but you also have the renin, angiotensin, aldosterone system, so that if blood pressure is low, if there's inadequate volume of blood going through the kidneys, then you produce renin, which is converted to angiotensin, which is a powerful vasoconstrictor, which brings blood pressure up, which pushes blood to the kidneys. Also, you get production of aldosterone, which increases sodium reabsorption, fluid reabsorption. All you have to know is that the kidneys play a vital role in maintaining normal blood pressure. You already know about erythropoietin and its importance in maintenance of normal red blood cell production. Red blood cells critical to oxygen delivery throughout the body, as you know, and activation of vitamin D, which maintains normal calcium metabolism. Now, just a couple of things at the end. Now we're down to the lower urinary tract. These are things you do need to know. Each of your ureters is about 10 inches long. The ureter is comprised of smooth muscle, and it's lined with transitional cell epithelium. Now, the fact that the ureters are comprised of smooth muscle means that they are capable of active peristalsis, so that they're actively squeezing urine toward the bladder. It's not just gravity, it's peristalsis that pushes urine from the kidneys to the bladder. The fact that the ureters are lined with transitional cell epithelium, let me just back up and tell you that the entire collecting system is lined with transitional cell epithelium. So the renal pelvis, the ureters, and the bladder. That means that you could develop transitional cell carcinoma at any point in the collecting system. But of course, what we typically see is transitional cell carcinoma of the bladder, because urine sits in the bladder for prolonged periods of time. It just flows through the ureters, flows through the renal pelvis, flows through the ureters, sits in the bladder. So I've seen many, many patients with transitional cell carcinoma of the bladder. I can't remember seeing a patient with transitional cell carcinoma of the ureters or the renal pelvis. Now, the last thing that I wanted to go over in relation to the bladder that's really important at this point is the fact that you have an anti-reflux mechanism. I want you to notice that the ureters actually enter the bladder at the base, not at the top. So that means that as the bladder fills with urine, you've got urine up above the level of the ureteral opening, which would create a significant risk for upward migration of bacteria and for pyelonephritis. Also think about the fact that when the bladder contracts, you could be pushing urine, pushing bacteria up the ureters. But we're equipped with a very effective anti-reflux system, and I wanted to go over the key components of that anti-reflux mechanism, anti-reflux system. First of all, the ureters enter the bladder at an oblique angle, so it makes it harder for urine or bacteria to get into the ureters because of the angle at which the ureters enter. More importantly, this is a cutaway showing the inside of the bladder. So here's the bladder lined with transitional cell epithelium. But I want you to pay attention to this triangular area at the base. That's known as the trigone. It's an anatomical landmark. It's the triangle formed by the 2 ureteral and 1 urethral opening. And you actually have another layer of muscle called the trigonal muscle that surrounds the ureters. And whenever the bladder contracts, whenever the detrusor muscle of the bladder contracts, that trigonal muscle also contracts to squeeze the ureters shut. So when the bladder contracts, the ureters are sealed, so you get no reflux. That protects us, and that's very important because you think how many women especially have had a urinary tract infection. Most women have had at least one urinary tract infection. Many women have had multiple urinary tract infections. How many of those women have developed pyelonephritis? Very few. Because this anti-reflux mechanism is so efficient and so effective, it separates the lower urinary tract and the upper urinary tract. Okay, so we talked about the anti-reflux mechanism. If you come down to the next thing on your handout, the major muscle in the bladder wall is the detrusor muscle. That is smooth muscle, not under your voluntary control. The bladder has 2 major functions. It needs to stretch and store at low pressures, and then it needs to contract and empty so that you have low residuals. We'll come back to that when we talk about continence issues. And then, the last thing is just the urethra, and again, we'll talk about this a lot more when we get to the module on continence. But we know there's major differences between the male urethra, female urethra. Female is short and straight, which means that females have a much higher risk of UTI and also a much higher risk of urinary incontinence. The male urethra, of course, curved and long, So that means that they have enhanced resistance to urinary tract infection, and they're much lower risk for urinary incontinence. Again, we're going to talk about that in much greater detail when we get to the continence module. So we're done with this section, and then our next video will be on indications for urinary diversions in adults. Thanks.